690, 2948 and 2023. Yes.
Hi, Madam Chair and members of the Senate Health Committee. I'm Representative Alyssa Kinney-Geyer from House District 46, parts of Southeast and Northeast Portland. And I'm really honored to be here today in support of both House Bill 2948 and 2023. These were passed unanimously by the House Healthcare Committee and the full House. The bills were two of several bills that were brought to me by Jerry Gabay and Julie Majors, whom you may remember from your informational hearing last September. Jerry, who can't be here today, lost his only child, Susanna, to suicide at age 21 and has made it his life's mission to prevent this tragedy from happening to others. He is a member of the NAMI Oregon Board of Directors, co-chair of the Providence Health Systems Collaborative Council for Behavioral Health, and a co-author of the Oregon Psychiatric Physicians Association Suicide Prevention Checklist, for which he received the Oregon Psychiatric Association's Access Award in 2013. Fortunately, Julie, who is on a similar life mission, is here today. After her daughter attempted suicide twice at age 16, she joined the NAMI Multnomah staff, where she hears from many families about the experiences that are sadly too familiar. Suicide is a major issue in our state. For years, Oregon ranked between 7th and 9th in the country for suicides, but has been increasing since 2000 at a much faster rate than the national average. According to the most recent data from the U.S. Centers for Disease Control and Prevention, in 2009 and 2010, Oregon had the second highest suicide rate in the country, and it's the second leading cause of death among Oregonians aged 10 to 24. In 2011, 685 Oregonians killed themselves, twice the number who died in vehicle crashes, and 6 times the homicide rate. In 2012, it climbed to 709. The financial cost is high. In 2010, hospitalization costs for self-inflicted injury exceeded $41 million. There are many challenges in filling the gaps of our fragmented mental health system, but one is making sure that we do a better job of reducing the revolving door in the emergency departments when people experience a mental health crisis. Another is a fear that providers have in disclosing information to those closest to patients when it is often critical to their care. This is especially important for adolescents and young adults who suffer from an especially high rate of suicide. Jerry's testimony on March 11th, 2015 to the House Healthcare Committee was, quote, to make us aware of 2 things which may have saved Susanna's life, which might save others in the future, and which he believes are encapsulated in House Bill 2948 and House Bill 2023. The first item would be much greater communication between providers and caregivers by blood or affinity. At minimum, providers must be encouraged to seek authorization to communicate with appropriate supporters of the patient and then actually communicate. House Bill 2948, the HIPAA bill, attempts to do this. There is ample literature indicating that extensive communication is a best practice for therapy and suicide prevention, unquote. OCAP, the Oregon Council of Child and Adolescent Psychiatry, states that communication between family members of persons seeking treatment for mental illness and healthcare providers improves the quality of care, reduces the risk of suicide and self-harm, and encourages the use of community resources to improve overall outcomes. Patients who are at least 14 years old may choose a family member or other support person as their lay caregiver. During a mental health crisis, when there is often a huge need for coordination, HIPAA, which is often misunderstood, actually does allow for communication in certain conditions. House Bill 2948 clarifies that the federal HIPAA privacy rule regarding conditions under which protected health information may be disclosed by a healthcare provider, sometimes without obtaining an authorization from the individual. The Director of the Office of Civil Rights and the U.S. Department of Health and Human Services issued a clarification of the HIPAA privacy rule in January 2013 following the Sandy Hook and Aurora mass shootings. The Oregon Department of Justice and Legislative Council both confirmed that House Bill 2948 is consistent with HIPAA and the privacy rule. The clarification enables continuity of care and clinically appropriate step-down treatments with engagement by family or friends as appropriate. We had very compelling testimony in support of the bill from Jerry Gabay, Julie Majors, Julie's daughter, and several other families. It is also supported by the Oregon Alliance of Children's Programs and the Oregon College of Emergency Physicians. There are 2 amendments since we passed this unanimously. One adds back the civil immunity protection that was in the original draft and was removed without our noticing it during one of the amendment processes before it passed the House. And this is a really important, this civil immunity protection. There's already in the law civil immunity protection for not disclosing information. And this just balances it out and says as long as you're following HIPAA law, then you're protected from civil liability at the state level. Lori Freeman of Legislative Council did say that it's never really been tested whether the legislature granting civil immunity will be upheld by the courts, but we feel that it's very important if you've got one civil immunity protecting non-disclosure that you also have civil immunity protection for people who are following HIPAA. Again, this does not allow people to go beyond what HIPAA allows. That civil immunity protection is strongly backed by OPPA, which is the Oregon Psychiatric Physicians Association, as well as OCAP, the Oregon Council on Child and Adolescent Psychiatry. That's the -4. The -5 names the bill after Jerry and Susan Gabay's daughter, Susanna Blake Gabay. I'm going to continue Jerry's testimony from March 11th, 2015. He said the second issue is that discharges from hospital care must be better coordinated with the resources in the community and with whatever support system the patient has. Communication must be robust rather than ignored, and the patient's support system engaged in the discharge process. House Bill 2023 is a giant step in that direction. It directs hospitals to adopt and enforce discharge policies for individuals that have been treated for mental health treatment. The policies must be publicly available and include at a minimum encouraging the patient to sign an authorization for the disclosure of information that is necessary for a lay caregiver to participate in the patient's discharge planning and to provide appropriate post-discharge support. And I want to just stop on the word encouraging for a minute because there's a continuum of everything from providing an opportunity for a patient to sign an authorization form to allow others to be a part of discharge. And then there's, on the other extreme, it can be coercing or pressuring a fragile patient into, identifying someone. And the word encouraging is meant to be in the middle there, where it goes beyond just handing an authorization paper, but really talking through why it's really important when somebody leaves to have a support person or persons in the community that can help them if there's a relapse or help them get to appointments, remind them of things like that, and really be a part of the support process. There is no intention whatsoever in this bill to do any kind of pressure or coercion for people to sign that who do not want to sign that. The discharge policies must include discussing the patient's prescribed medications and the circumstances under which the patient or lay caregiver should seek immediate attention. The discharge policies must also include a process to ensure coordination of the patient's care and a transition from an acute care setting to an outpatient treatment that may include community-based providers, peer support specialists, lay caregivers, or others who can execute the patient's plan following discharge. The -5 before you clarifies some minor issues brought up to me.
Wait, are you on 2020?
I'm on 2023.
Yes. Okay.
So this one also has an amendment that came after the House passed the full version. These were some issues that were brought to me by Providence right before our final chamber deadline, and so we decided to deal with them in the Senate. There's a couple minor kind of language and clarification changes. The one I want to highlight is the one at the end, the 7-day goal for a follow-up appointment on discharge. Since the 7-day goal is a CCO metric and is based on best practice, we want to ensure that hospital discharge policies aim for the same goal as the CCO system is doing. While the 7-day goal is not a mandate, it is clear legislative intent that this be a goal. Requiring documentation about why the 7-day could not be met will help ensure that the discharge staff work hard to find an appointment with 7 days, but it also allows for the fact that sometimes it's very hard to find provider availability, or perhaps there's someone on an 8th day that's an in-service provider, in-network provider that they couldn't have on a 7th day, and that means that the patient might have to pay a lot more. So that may be in the patient's best interest, or there may be a facility that has a better fit for the patient, and that may be on 8th or 9th day instead of 7th day. So it allows some flexibility for the providers to do what's in the best interest of the patient. I appreciate input from consumers, mental health providers, insurers, hospitals, and the Association of Hospitals and Health Systems, who have also been working on the CARE Act to create discharge policies for mostly seniors who need help with post-discharge care. Again, both these bills passed unanimously. We've reached out very broadly for input about the amendments, and there seems to be broad agreement on the amendments. And I encourage your support. Happy to answer any questions.
Thank you. Lou.
Thank you, Madam Chair and members of the committee. I'm Lou Frederick, representative from District 43, North and Northeast Portland. I guess I'm here not so much in terms of the details of the bill, as to both of them actually, 2948 and 2023, as to tell you, at least to give you a sense of why I began working on these things quite a while ago. In 1991, my wife began a process of every 3 to 6 months being in an emergency room or a hospital, a mental health ward usually there. I would arrive home and I was never sure who I was going to be greeting. She would either be catatonic or she would be non-communicative or perhaps sometimes very combative. But it was every 3 to 6 months. And we would find ourselves in the hospital. When we got there, she would be there for 3 days to sometimes almost up to 2 weeks. The problem, though, is when she was released, I did not know what kind of medication she was taking, what kind of behavior I should be watching for, what to do if I saw anything, and who to talk with. Because depending on the hospitals, and believe me, we went to all of the hospitals in the metro area at one time, depending on the hospital and the people in charge of that particular ward, they would tell me or not tell me about what was going on. And the discharge issue was a significant one because you're sitting there trying to figure out what's going to be best for your loved one, and you can't figure out what that is because no one's telling you things. This is an attempt to try to address that. Now, I should also tell you that as a result of the years that she's been working with this, she's been working with NAMI, and they had a good little walk yesterday. You couldn't come this time. And North Star, which is a clubhouse, what they call a clubhouse. She is also teaching peer support classes now to other folks who are struggling with this, and first steps, where she goes into the hospital to suggest to those folks who are there how they can what they can do once they leave the unit, and where they can get support. These are the kinds of things that are helping her a great deal. But I will say that it would have been a lot better for us as a family and for me personally to know what was going on with her, what medication she was taking, what I could do to help, what I should watch for. Because believe me, every 3 to 6 months in a hospital, not a lot of fun. And even when she wasn't in the hospital, she was often struggling. She's doing relatively well right now, but I think this will help other families deal with these issues. So that's why I'm here, and I hope that you will support this legislation. Thank you.
Questions? Thank you very much.
Sure. You gonna be able to get it?
No other. So let's call up Jennifer Pepin, Julie, is it Maggers, and Cheryl Ramirez. And I think you signed up for both bills, so please.
Hello, Chair Mona Sanderson and Vice Chair Cruz and esteemed members of the committee. My name is Jennifer Pepin. I am myself diagnosed with bipolar, but today I'm here as the loved one involved in my fiance's hospitalization after a suicide attempt this past summer. I urge you to pass House Bills 2948 and 2023 because I believe they will help people like us. When Chris was brought by ambulance to the emergency room, he said, "When I go home, I'm just going to do it again until I'm dead." Although this was said through the many pills he had swallowed, and he may not even recall making that statement, I believe had it not been for the proper treatment and planned out aftercare, it would have become our reality. Immediately with my arrival to the hospital, I was faced with having to advocate for Chris. He was left in a room in emergency with no clear plan of what steps were going to be taken. He was in no state to ask for assistance himself, and I couldn't get anyone to explain things to me, even though he had signed a release. After about 17 hours and my persistent inquiries, they finally told me they arranged for him to be transferred to an inpatient program. Not in his right mind, Chris, of course, wanted to come home immediately. He was on a hold and had no choice but to stay. However, once that was lifted, without notice to me, he said he was packed and ready for me to pick him up. At this point, he was not stable, had not been through any proper diagnosis, treatment, or therapy. I never spoke to a doctor, nor was I included in discussion of a discharge plan, and I began to panic at the thought of Chris coming home. My questions were, will he again try to end his life? What are the next steps? Is he just supposed to go home and fall into old routines that led him here in the first place? I told him that I would not let him come home unless there was a schedule mapped out, including all appropriate aftercare. It was only because of a friend and mental health advocate that I even had the strength or knowledge to say those things. I was wishing there was someone on the other end at the hospital who would be telling Chris the same things, but I had no idea what he was being told. Fortunately, after an adverse reaction to a new medication, Chris agreed to stay longer at the hospital. This gave us time to come up with something on our own for aftercare. Without speaking to his doctor, we wrote out the days of the week, and I made Chris outline what his daily recovery would look like, including doctor appointments and activities. I had nobody at the hospital guiding me if this was the right plan. Even when they eventually had a discharge plan, I was not part of that process, even though Chris had signed a release to involve me. I did not know what his discharge or aftercare plan included, and because of my lack of involvement, I was quite anxious about Chris's return. I had absolutely no idea whether he would follow my plan or if there was further information from the doctor I didn't know about. It would have been more appropriate for us to knowingly be giving Chris the same message. And remember, I myself live with bipolar disorder, so this lack of communication and coordinated planning was not healthy for either of us. I'm so grateful that 10 months later, Chris is doing very well. I believe that although the plan he followed was created on my own, it was following this regimented recovery plan that has made the difference for him. It would have made everyone involved feel much safer to have had the opportunity to work directly with the medically informed doctors who would have known more than I did. When faced with that situation, it is incredibly difficult to think straight, and had it not been for my friend's help, I would not have known what to ask or plan for. I know if roles were reversed, I would have wanted Chris to be involved in the discussion of my care and discharge. It is so important that there is a set standard to guide both doctors and families to accommodate the release of a patient from the hospital. Thank you for your time and attention.
Thank you so much for sharing your story.
Chair Mona Sanderson, Vice Chair Cruz, and esteemed members of the committee. My name is Julie Majors. I work for NAMI as a parent advocate and educator, helping parents learn how to navigate the system for their children and adolescents. And I'm also a parent. I have a 24-year-old, and my daughter will be 21 next week. At 16, she didn't believe she was going to make it to her 17th birthday. She had been struggling for 5 years in a downward spiral with untreated or undertreated depression and anxiety disorder. She was self-harming since middle school, and a lot of people were concerned, but we really didn't have very good direction on what to do with those concerns. When she was a junior in high school, she had been long enough in pain that she made an attempt on her life. She told me that she didn't really want to die, but she really couldn't live with the pain that she was in and no answers and no hope moving forward. So we ended up at the hospital. She became stabilized, and at discharge, she had been put on a new trial of medication, which I was concerned about, but I also didn't know any better myself and trusted the care and the expertise of the doctors. The doctor who prescribed the medication told her that he thought it was her best bet at feeling better. Little information was given to me about how to keep her safe or understanding suicidal ideation. And we essentially were told to go to our outpatient appointments and then back to school and try to make life as normal as we could, which we readily followed. But the following 2 weeks, my daughter didn't feel better. She actually felt worse. She had worse side effects, and her mind told her, the doctor told me this was my best bet at feeling better, and she attempted a suicide again. Back in the hospital, there was kind of a repeat process of stabilizing her, taking her off the medications, and then a discharge plan to send her home again with the same information that we had and the same plan to go to the outpatient providers that we were seeing. But I didn't feel that this was really adequate, and I was very frightened and traumatized at the time as well. So we insisted, with a lot of support from knowing advocates and people who were case managers and folks that I knew from the work I was doing on health reform. I had a very sophisticated support network that coached me on what to say to whom and when. And we ended up, by the time of her second discharge, spending a 30-day residential stay and discharging from there a very solid, coordinated care plan that was really meeting her needs much more. So she is doing well today. In September, my colleague Jerry Gabay and I were asked to testify and bring forward our stories. As you know from Representative Kenny Guyer, Jerry lost his daughter, and he presented information that he thought were practices that might have saved her life. And I can tell you that those very practices are indeed what saved my daughter's life, in so much as I was really able to insist that we move those practices forward. My daughter is doing very well today, and I thank God every day that that's the outcome that we've been able to have. I work with a lot of parents who don't know this journey, and they don't know the details of what to do and what to say. And I really urge the support of both of these bills. I think that they're going to go very far in making a difference, and the work that we all do moving forward. Thank you.
Thank you very much.
Good afternoon, Chair Monis Anderson, members of the committee. I am Cheryl Ramirez. I'm the director of the Association of Oregon Community Mental Health Programs. And on behalf of the Community Mental Health Programs, the publicly funded mental health delivery system, we support both House Bills 2023 and 2948. We really strive for prevention of suicides and suicide attempts in the community with early intervention with individuals and their families. But when a person does get to the point that he or she is in the hospital, in the emergency department, we believe strongly in warm handoffs between the hospital and the care coordinator. That's essential for their well-being. I don't usually give personal examples, but I feel compelled to say that I'm a family member of a person who attempted suicide, and I was extremely thankful that the crisis worker happened to find my cell phone number. I still don't know exactly how, but I found out. I was, at the same time, I was extremely anxious and terrified when I found out that they released him with no one. He literally walked home from the emergency department that evening, and there was no care coordination whatsoever. I do have private health insurance, and that would bring me to a couple of other points I wanted to make, which is I believe there are gaps in care coordination among payers. It's not consistent. And I think that we need a consistent process for community members regardless of their payer, of how they are covered or whether they're covered or not. And then secondly, in the future, I would like to see us apply the discharge policy to people who are not admitted to the hospital. For example, my loved one was not admitted to the hospital. He was just in the emergency department. So hopefully in the future we'll add that. Thank you for the opportunity to testify.
Questions? Senator
Thank you,
Shields.
Madam Chair. Can you tell us a little bit more about the discrepancy amongst payers?
Well, for example, in Medicaid here in Oregon, coordinated care organizations have care coordinators, and they pay for care coordination. So whether that's by subcontracting to the community mental health program, or I'm not sure if some CCOs have care coordinators on staff, but they actually pay for that service, and so it's a possibility. It's for someone to come to the emergency department and be able to literally take that person and help them, when they go back to the community. That is not the case with all health insurance plans.
Thank you.
Other questions? Thank you so much for your testimony.
Thank you.
To Adamson, Patty O'Sullivan, and Chris Bonoff.
Madam Chair, members of the committee, for the record, Jessica Adamson with Providence Health and Services, and we are here in strong support of House Bill 2023 and 2948 with the amendments as described by Representative Kenny Guyer. We appreciate the courageous leadership of Julie and Jerry in bringing their stories forward and sharing them and working to improve the lives of those that struggle with mental illness. It's a priority for Providence to get this right and to work on discharge planning that is meaningful, that engages families and caregivers, and make sure that the folks that are in our care leave ready to take the next step in recovery and stabilize their loved ones and be able to move forward, getting to solid chronic management of what may be a chronic disease. We fully support the amendments and particularly thank Representative Kenny Guyer in working with us on the Dash 5 to House Bill 2023 that makes some solid improvements in the bill. And thank you very much for the opportunity to share our support, and happy to answer any questions.
Chair Mona Sanderson, Vice Chair Cruz, members of the committee, I'm Chris Bonoff here representing the Oregon State Chapter of the National Alliance on Mental Illness, and I can be very, very brief on this. Speaking just to House Bill 2023, NAMI's in favor of the bill with the Dash 5 amendments. Others have spoken more articulately than I can about the need for that legislation. And it would just point out that it's rare in our area of the world that we have this level of unanimity on any legislation dealing with mental health, and so very pleased to support this legislation and looking forward to working with the individual hospitals and the Hospital Association on developing many of the protocols that will assist families in dealing with inpatient psychiatric care. Thank you.
Very much.
Good afternoon. For the record, my name is Patricia O'Sullivan. I represent the Oregon Association of Hospitals and Health Systems. And I, too, am here today in enthusiastic support of both House Bill 2023 and House Bill 2948. House Bill 2023, the subject matter surrounding House Bill 2023 is it's very heartfelt. You've heard some stories here today. It's also something that's been very apparent to the psychiatric, acute care psychiatric units in Oregon. There's 15 of them. Even though we have 60 hospitals, there's actually 15 acute care units where you go for a very short stay when you're acutely sick with a mental illness that has something has gone wrong. That is meant to be a short stay, and then you're supposed to move on to back home to another facility or for a long-term psychiatric help. Most of these folks come into our emergency rooms and spend a certain amount of time there. It's not supposed to be long, but in today's world, it ends up being longer than it should in a lot of times, a lot of cases. So the Hospital Association actually had a committee during the interim that worked on mental health issues, and we had 2 bills. One came through this committee and was actually just passed out of the House committee today, and the other one was House Bill 3502, which did not get a hearing because we were told that we would be working on this in the interim. We want to be at that table because our front door issues, our back door issues, and our issues with the commitment process specifically are need help. We know that we can do a better job, especially in discharge planning, whether they're out of the emergency room going home or whether they're out of our acute care unit, either going to another setting, going home, or going to the state hospital. So we understand that, and this bill is ended up being a companion bill quite by accident to a bill you're going to hear on Wednesday, and that is the AARP bill of House Bill 3378. The AARP bill sets up a kind of a skeleton or an outline of discharge planning for everybody in our hospitals. Doesn't matter who you are, 2 days old, whoever you are. And then this bill, when it came about, we all worked very hard to make sure that it was a companion bill meant for those folks being discharged from our acute care psychiatric units, or they could be up on a med-surg floor. They could be wherever, with a mental illness. It doesn't have to be there. But when they're leaving, this would be a companion bill. So you'd have to do this for everybody. In addition, you do this for those being treated for a mental illness. Does it go far enough? Probably not. It was a really good negotiated compromise, I think, and I hope everybody thinks, for now. And I believe there will be much more work done on this. In fact, the head of our OPIC unit, or our OPIC Council, which is the Oregon Psychiatric Inpatient Council, that has the director of all 15 acute care units. It meets monthly at the association. The chair of that council and Mr. Bonef are getting together with others and creating protocols to fit the outline of the discharge planning. In other words, you don't want to put everything protocols in statute, but this is where they're building a set of protocols, and we'll get those to every one of our acute care units and our other hospitals for discharge planning. Again, we're very supportive. If you have any questions, I'd be glad to answer them.
Seeing none, thank you very much, panel. We'll be bringing them back when the amendments come. I will close the public hearing on House Bill 2948 as well as House Bill 2023, and we're going to go back.